Good morning, everyone. Good morning, everyone. Oh, there we go. There is coffee over there if you need it, okay? All right, well, welcome to this session. Before we get started, I'll just ask you to take a few moments to take a look at the screen. This is a webinar that's being hosted by ICUDDR, so we want to make sure that everyone gets this information for today. And please join if you can, and share with friends and colleagues. All right, well, my name is Susan Garrett, and I'll be your moderator for this session. We have 4 presenters with us here today, so each of them will be presenting for about 20 minutes, and towards the end we should have plenty of time for questions and answers. I think we might have up to 20, perhaps even 30 minutes to do that. So we encourage you to take notes and prepare those questions for the end. So today what we're going to be talking about in this session is the systems change and the role that the university, the role of the university through the lens of the ITTC network plays. And this is actually part 2 of a 3-part series. Perhaps some of you attended yesterday's session where we introduced the systems of change. And I say we because I'm also part of the ITTC network, and also gave some examples from 3 of the ITTC centers from Nigeria. We heard from Thailand, and now I'm blanking on the third one. It was you, Lori, yes. We heard from the network coordinating office, the person that I see and talk to every day. How could I forget? So today we're going to be hearing from some of our other ITTC centers. We're going to be hearing from Vietnam, South Africa, and the ITTC in Peru. Our first presenter is Dr. Trang. She has a background in clinical psychology and political science. Her expertise includes qualitative research and behavioral health interventions. She's been involved in research, training, and technical assistance on treatment for substance use disorder for professionals throughout Vietnam. Her research includes feasibility studies, clinical trials, and evaluation of behavioral intervention models in Vietnam. She is interested in implementation science and how to adapt and deliver evidence-based interventions in low and middle income countries with limited human and financial resources like in Vietnam. So with that, please help me welcome our first presenter, Dr. Trang.
So, hello everyone, and thank you, Susan, for the introduction. I'm a bit nervous to start the lesson, so please bear with me. So actually today I'm here to present an initiative of our team that we are very proud of, that a pilot project to enhance the community reintegration for people with history of drug use in Vietnam. So, we won't go through the presentation. At first, we will talk about the rationale, why we need to care about the community reintegration for people with the substance use and substance use disorder. Then I will describe the pilot project, and we're gonna look at the project impact through the lens of the system change model. So first, why? So as you can see here on the left-hand side, that today, in East and Southeast Asia, there are still like 500,000 of people with substance use being sent to compulsory drug rehabilitation every year. And we all know that actually the experience of being in a compulsory drug rehab is associated with poor outcomes like unemployment, poor health, stigma, and a high relapse rate. So, one reason for that is that the people who are released from the compulsory drug rehab, they are not connected efficiently to the community-based research services. And we also have more favorable condition in Vietnam, as shown in our new drug law that emphasize the community-based rehabilitation support services, and we want to help the government of Vietnam to implement this policy, to translate this policy into actual work. However, we do have some challenge, that is the limited capacity workforce, and provider stigma is still pretty significant. So at the very beginning, our team came together and we brainstormed on the intervention that might be feasible to integrate it into the existing system. And we didn't want to come up with totally new intervention that we think that this is not a sustainable way. So we want to find interventions that are adaptable to the existing system. So this is what we came up. So you can see here in the blue circle here, this is the existing model. So in the community, there are lay social workers who are mainly like retired senior who go into their community, who do the monitoring of people who eavesdrop in their community, and then refer these people to the services. However, this model still encounter a lot of challenge and is not efficient. So this is why we decide that we're gonna add two evidence-based intervention here. One is the motivational interviewing, and the other is the online case management through the form of online support group. So in order to implement the intervention, we have done quite a lot of preparation work, like we do the training, we develop the materials like a handbook of local services, and we also develop a library of SMS that to deliver the information about the available services, and also to facilitate social support to people who eavesdrop. We do evaluation at baseline and post-intervention. Here are some pictures of the development process. These are the lay social workers who came together to work on the challenge, opportunity, working with people who eavesdrop, and also our colleague here are working with the local service provider to gather input for our handbook and the training. We conduct this pilot within 9 months in 3 communes in Hanoi. We work with 15 lay social workers, and for participants, we select the people with history of drug use who possess a smartphone and consent to join, because we're gonna deliver the SMS and work, do the online social support group. So that's why we need people with access to a smartphone. Now let's look at the findings through the lens of the system change. For the first condition, policy, as I mentioned earlier, that we do have a favorable legal framework, but still the policy has been effective, if I'm not wrong, from January 2022, so it's still pretty new. So we do not have guidelines for implementation of community-based rehabilitation support services. But still, the government want to pilot the community-based support for people who eavesdrop. So this is, here's the Hanoi target, the capital of Vietnam, where we do this pilot. Is like by 2025, all the community need to implement this support for people who eavesdrop. However, the Hanoi people, they struggle a bit because they don't know how to implement this model. So what we contribute, the pilot support Hanoi in achieving its target. So we also demonstrate a promising model for supporting community reintegration of people who eavesdrop. That is for the first condition, the policy. Now we go to the practice. Regarding the practice, the usual practice is that the lay social worker only care about the client drug use status. When they go out in the field, when they check on with their clients, they only care about whether the client is abstinent or have relapse. and they often do not reach out actively to people who use drug to provide information. And on the other hand, people who use drug, they are reluctant to go and see the lay social worker and also other government officials. So what we change? So in our project, we have the lay social worker to conduct a comprehensive assessment on clients' needs, and the needs is not just like drug use related, but also medical needs, employment needs, social support needs. And the lay social worker also use like in-person motivational interviewing to build trust and to promote the client change. And we organize the online support group for both the people who use drug and their family members. And through these groups, we provide information about the available services and also social support to people who use drug and their family. Now to the third condition of the system change, the resource flow. So for the resource, we have the one strength is the stable government-funded network of lay social worker in most communes. But we do not have yet financial guidelines to implement the community-based support for people who use drugs. So this is one reason why the pilot project led by the government has not been effectively implemented yet. So what we change? So we leverage this government-funded lay social worker in our model. And we provide training not just for lay social worker working in our project, but also to lay social worker in Hanoi in general. And now to the relationship. Here, when we talk about relationship, we talk about relationship between different sectors and relationship between the lay social worker and their clients. So regarding the relationship between different sectors, often in Vietnam, the social and medical sectors do not collaborate very effectively. So the lay social worker are under the social sector, and they do not collect the health-related information, and they do not understand correctly like evidence-based treatment for addiction, like methadone treatment. So what we change? At first, we have our lay social worker to be equipped with information related to methadone, HIV treatment service, and with this information, they provide to their clients and refer their clients to services. And also through the pilot, we have been able to create a more trustful relationship between lay social worker and their clients. And the pilot also offer and have strengthened the collaboration between the lay social worker, between Hanoi Department of Social Vice Prevention and our team at Vietnam ITTC. And you can see here that there are some of the observation of the lay social worker. So I think this quote is pretty interesting. Like one lay social worker said that before, when when one client see him, he gonna turn away to avoid him. But now, during the project, after having met the lay social worker for several times, now they can go straight and meet him. So I think that's a wonderful change. Power dynamics. So now we talk about the power dynamics between the different sectors working with people who use drugs. Like in Vietnam, there are the police, there are the social affairs sector, and there are the medical sectors. And we represent the public health approach, and the public health approach still struggle to expand its impact. And in Vietnam, drug issues are mainly under the police, and we want to have a larger role in the recovery and in the treatment and prevention of drug issue. So what we change? Here we have trained the lay social worker to assess their clients' need for healthcare and to provide information related to medical treatment. So here we emphasize the importance of the public health approach. And now we come to the last, and as Lori yesterday mentioned, that's the condition that gonna translate what we change, what we contribute into drastic change, the real change, the mental model. So the existing mental model in Vietnam is still very dominantly abstinence as the ultimate role of community reintegration for people who use drugs, and stigma toward people who use drugs is still very prevalent. What we change? So this is a pilot project, and even it's a longer project. We do not expect that we can change the mindset of people within a short term, but what we do is to somewhat change the view of lay social worker on the problems. And so lay social worker, they were instructed to assess the comprehensive needs of their clients, so including like employment, medical care, and not just drug use. Lesson learned. So what do you know throughout and after we have completed the pilot? So we know that actually the lay social worker, they would welcome and practice evidence-based intervention that makes their work easier and more rewarding. We also know that the lay social worker, they are a great resource for community support for people who use drugs. And we also know that the policymakers, they would welcome initiatives that assist their goals. Also, people who use drugs respond well to being given social and information support beyond drug-related matters. What we hope to achieve in the future. So here I list on the, so here is combination of both short-term and long-term vision. For example, for the short-term one, we plan to provide more training on evidence-based intervention for lay social worker. We also want, that's a midterm, we also want to enhance the government existing information system to cover non-drug related needs of people who use drugs. For intervention, we will further update our SMS library for online support group. And these are and the next one will be for far longer term, is to shift the mindset of people from abstinence focus to quality of life focus. And we hope that we can foster greater collaboration between social and medical sectors. And this picture shows the collaboration between different stakeholders in this project. And with this, I would like to end my presentation. Thank you.
Thank you so much, Dr. Shang, for that very informative presentation on how lay social workers can really have an impact on the system. All right, our next presenter is Dr. Sibeko, and he is from the International Technology Transfer Center in South Africa. He serves as Associate Professor and the head of the Division of Addiction Psychiatry at the University of Cape Town, and as Director of the U.S. Department state-funded ITT Center in South Africa. His work has focused on interventions using non-specialist workers in the management of severe mental illness, and he has a developing research portfolio focused on task-sharing models for the treatment of harmful substance use, mental health, and HIV. Dr. Sibeko has an established international collaborative network and has been very instrumental in advancing the strengthening of mental health training for community health workers. He has developed a growing body of research work and implementation of interventions for the overlapping pandemics of behavioral disorders and HIV. Dr. Sibeko has led and participated in policy development and implementation activities for mental health and drug demand reduction in South Africa and in other in other African countries. With that, please help me welcome Dr. Sibeko.
Good morning. Good morning. I'll never get used to hearing my own eulogy before I speak, so it remains really weird. I want to just start by saying that I don't get nervous when I present in general, but when I'm presenting to my own people, I get very nervous because I know how much you value the work we do. So support me through this, won't you? So we're based. Thank you, I appreciate you. So I'm coming, as Susan mentioned, from University of Cape Town, which is based right there at the bottom of the African continent. We're at the University of Cape Town, which, as you can see, is an absolutely stunning campus. And we're based in the Neuroscience Institute at the world-famous Groote Schuur Hospital, where the world's first heart transplant took place. So we're hoping for some reason or the other that you may have an opportunity to come by and see us. So please come see us, and I'll show you more of Cape Town, and I'll take you around and show you the things we do there. So it's weird, Susan, because this doesn't change, but that changes. That's really weird. Okay, so this is the updated ITTC network map. So everybody in this room is very well aware. So I want to say welcome to all of our new friends, and nice to see you again to our established friends. So yeah, this is not moving.
Presentation mode.
Is it not on presentation?
Right
I thought it was.
Oh, it's not going.
It is. It's not going.
It speaks Greek, so.
Is it?
Let me just try to get it.
All right. So in the meantime, it's just much easier to see what you're talking about if it's in front of you.
If you click on these signs on this end, does that change anything for you?
Let's see. It's not working. It's okay.
It's okay.
So the ITTC in South Africa has three main aims, and our activities are geared towards meeting these. So I just reduced the slide to focus on the last two because that's really where I want to focus on demonstrating our systems change interventions. But as Susan alluded to, a lot of our work is in the policy space, where we look at what policies are in existence and see in what ways we can galvanize and support the systems to implement those policies. And where there needs to be input in bringing policies up to date with the best practice, we're involved in that. And we've had the great privilege of forming an excellent relationship with our national departments which are responsible for drug policy in South Africa. And as a result of that, we also work closely with members in the Southern African development community. I'm going to slow down because I know that interpreters are going to strangle me any moment now. So I'm going to slow down. I can see the anxiety on your faces, so I'm going to slow down. And then also on the African continent through our collaborations with the African Union Commission. The second is, again, something that is bread and butter of all ITTCs, which is really training. So improving the uptake of best practice through training, interventions, and technical assistance. Not going to go too deep into that, so it's basically providing training in MI, in SBIRT, providing specific technical assistance as required for policy or implementation. Where the focus of today is really going to be about assessing and removing barriers to evidence-based practice. So in order to know how to improve the delivery of or the implementation of policy, you need to have the data that shows you what the policy implementation is doing on the ground. So some of the interactions we've had with our policymakers are about what are their gaps, and I'll get to that in a moment. So in trying to meet that, we've developed the web app Assist, which I'll talk about in some detail today, as well as a substance use disorder resource map, much akin to the one developed by our friends in Vietnam. Okay, now nothing's working. Let's see. They're coming. Okay, there we go. It's moving, it's moving. So the overarching principles that I think what's very important, so Laurie, you'll excuse me in that I'm going to infuse the change principles across the talk as opposed to having specific slides about them, although I might have a reflection slide at the end. If you're going to work with collaborators, part of forming that relationship is understanding what drives them. So understanding what the vision and mission of that organization is. And that's what makes the relationship between ITTC, ISUP, ICDDR work, because we all understand what our core function is. So we work primarily under the stewardship of the National Department of Social Development, who are the custodians of drug policy in South Africa. So their vision, as you can see, is really about creating a caring and self-reliant society. And that's really been an underpinning element of how we've developed the Web App Assist, and I'll speak to that in a moment. And the rest of the mission you can read. The vision of the Vision 2030 for my university is around a faculty and academic institution that's responsive and is embedded in the community, and that creates innovative solutions that are socially responsive and grounded in what the community needs. And these are principles which I think are carried through well in how we've developed the Web Assist. So, those were like like when you go to a movie, you get all the previews. Those were all the previews. So now the presentation starts. So I'm just going to very quickly talk, that's my team. So I'm going to talk a little bit about the genesis of the assist, describe it very briefly to save time, talk about the pathways and linkages, so hopefully you can see how the development helps answer some of those questions and helps policymakers reevaluate their policies and see where things need to change to really be impactful at the community level. And then I'll do a quick systems change reflection. So this all started because the Department of Justice and Correctional Services says, well, we know exactly what drugs are in our system because we have seizures. So when we go to correctional facilities, we know which drugs we're finding. We know which drugs are coming through our ports because we have seizures that are through law enforcement. What we don't know is how this data matches with the levels of substance use within the prison system. And beyond that, how many folks within the prison system need care and attention for substance use disorders? So for us, this was a wonderful question from Department of Justice and Corrections because it already said to us they are concerned about the well-being of inmates. And I think this is something you will see across the spectrum of interventions by our justice and corrections. It really is a person-centered system to the extent that our public actually complains sometimes. Why are you taking such good care of them? But if we talk about alternatives to incarceration, you can see that our justice system is already well poised because already the system of justice and corrections is geared towards being person-centric and holistic and really about help preparing the person for reintegration into society as a better person. So they wanted to know not who's using, because that wasn't the aim, but what is the prevalence of levels of risk of individual substance use that require specific interventions, so that the department could then reorient services or mobilize resources. In addition to that, it was about, it's not moving here. So in addition to that, it was then about, once you know what the problem is the workforce within Department of Justice and Corrections ready to meet the challenge? So it was also about creating capacity within Department of Justice and Corrections so that they are able to capacitate their staff in meeting the needs of inmates with needs for harmful substance use. It's this one. I think we're supposed to have a dancer at this point, so just sort of pass the time. I can't dance, so I'm not going to do that. That's progress. Thank you. Wonderful. Why is that so small? Can you make it bigger? Wonderful. Thank you. All right. So let me fix it my way. There, that's better. And so what Department of Corrections wanted to then do is to take the data that was generated by this fact-finding mission, which was also tied to a capacity-building mission, into a document with findings that they could then use to inform policy and strategy modification. So that was the original mission. So what we then did was we trained the management of Department of Justice and Corrections in how to do SBIRT, and we focused on the assist tool, which all of you are very much aware of, but I'll talk about why we chose it in a moment. And we capacitated the core management in what expert is and what motivational interviewing is, and gave them the skills to train providers within corrections. So they did that. What they then did, the providers, we're talking about the wardens who do the intake, we're talking about the social workers who do the social review, and the health practitioners within corrections who do the health reviews. They then administered the assist screen. We then collected this data, so it meant that facilities would collect all the paper screens that they'd conducted. They would be sent to a central location. From that central location, they would be sent to UCT, to my team. My team would send it to the data capturers. Once it got to the data capturers, we'd send it to our stats people. That's a very long and arduous process. And so at certain sites, we had challenges which were related to geography, to transport, to human error. So we said, well, how do we fix this, right? And so that's what resulted in the development of the web app version of the Assist. So out of interest, the initial data sort of collection, so it was really up until the 15th of March. So we did about a 2-month period of piloting the use of the paper version of the Assist within corrections. So we captured the data on the 6th of June. So you see that lag. 28th of June is when we were finally able to start analyzing. At this point, we had 87 variables, and we were able to sort of analyze 218. What was really exciting for us, I'm mumbling past that because you can read it yourself. I always say to my students, I'm not going to label things you can go find for yourself. I'd rather talk about things that will benefit you from what I have to say in addition. So we additionally collected demographic data and facility data. I'll speak about Sekendo in a moment, but what was really great to see is that the patterns of risk within correctional facilities were geographically similar to those that we noticed in the Sekendo data. Please don't panic, I'll tell you about it now. And the SASH data. The SASH data is the most recent epidemiological data we have in South Africa for mental health and substance use disorder. And it's old. I think the last observation for that data was 2008, so it's completely outdated. But it was interesting to see that the patterns of risk still seem to match that data. Low levels of alcohol, no surprise, because of the restrictions. And DCS has already used this data to start reviewing their systems to meet the needs of substance use disorder clients. So why did we use the Assist? So this is the QR code to the Assist. If it pleases you, you are welcome to point your camera at it, and so you can go look at it yourself while we speak. So it's on a few slides. So if you miss it on this slide, don't despair. You'll get it on the next slide. So please go in, take a look, play around with it. You can enter whatever data. You don't have to. You can either screen yourself or you just play around and put whatever. So why did we choose the Assist? You know about this, that it asks about recent substance in the past 3 months and also asks for lifetime risk. So it allows us to get a nice picture of lifetime and the recent 3 months. It's got a comprehensive list of substances, which is great because it's one tool, has all the substances, so we like that. We like that it provides a level of risk for each substance. Again, you know this. We also very much like the second portion is the brief intervention component. Whenever we talk about expert to policymakers, they always say, well, what's the point of screening if you can't have the treatment facilities? Because as we know, there's a shortage of treatment facilities. So we say to them, well, ultimately, only 5%, only a very small portion of people actually end up needing very specialized assessment and care. The rest do quite well when they become aware of their level of risk, when they become more aware of the specific risks that are related to using each substance. So that brief intervention, while the expert itself might suffer from the lack of referral facilities, is in itself an intervention in the meantime. So it's that question of let's do something now while we work to reorient the system and move resources into place. So this did very well within corrections. People really enjoyed it, and it reduced that whole burden of sending the hard copies and removed the human error element. And so I'll talk about the characteristics of the web app that helped do that. But then what happened is we also work very closely with other departments, Department of Health, Department of Monitoring and Evaluation, Department of International Relations, etc. They then said, well, it's great that working there, but can it work anywhere else? So it was about translating what we've developed as a collaboration with one partner, and in that way building trust and a relationship with government in general, and then taking that further to look at where else it can fit. What challenges were we trying to address? The government said, well, we don't have comprehensive epidemiological data for South Africa for mental health and substance use. I mentioned the SASH study, which was done in 2008, but right now we don't know what the levels of challenges for mental health and substance use are. We don't have a passive risk map, and I suspect this is a challenge you all face in your countries as well, is you are able to report on treatment demand, but you don't know, the community at rest, what are their levels of risk. Whereas we have people coming in for surgical outpatients, medical outpatients, and other areas of care, where there's an opportunity to actually screen them so you have a sense of what the passive risk is. There's no money, we know. That's why half of us aren't here. And the current strategies in South Africa are limited. So there's limited indicators for mental health and substance use. Now, Secendo is something that was developed by our friends at the South African Medical Research Council, where treatment centers send them data so that the South African Medical Research Council can have a sense of what the treatment demand is. So we know what people are coming to get help for, but we don't know what people's passive risk is in the community. So we're getting the people that now need help. So we need to figure out who may need help in the future in the community. So that's the purpose of developing the Web Persist. So there's that QR again, and there's the URL if the QR code is not working, or if you haven't updated your phone and you're still on a phone that doesn't use QR. Yes, I'm judging you. Is that it is anonymized, so we don't capture identifying data, but where there are specific projects that require identification, we can modify it to do so. It generates a random code which can be tied to a client's folder or file, so that if down the line you lose the screen and you want that, we can easily retrieve that for you. Any device, data light, automated. And for me, the most important is it reduces training burden, because a lot of our partners don't believe in Cascade training. And we're actually busy testing Cascade training in a project in South Africa now that I'm MPI of, where we are seeing some challenges with Cascade, even though there are elements of it that work really well. So this reduces, the reality is it actually eliminates training burden. So if you play with it now, you'll see that anybody can do this. You don't need somebody to tell you how to do it, because it's automated. And because of that automation, you don't have to remember which substances the client said yes to, because all of the ones the client says no to fall away. Thanks, Hala. So we've developed 3 pathways. I mentioned about the goals of the Department of Social Development for creating a self-reliant society, which is why we wanted to make sure there was a self-screen option. We need people to take responsibility for their own well-being and to give them tools to do so. And that's why we wanted to make sure there was a self-screen. There's a practitioner version which uses a practitioner profile, which allows a practitioner to go back and revisit screens that they've done. But it also means that if you get a screen here and you get a screen next week in Portugal, and if it uses the same platform, there's a reliability in that the system works the same. Then, of course, we've had special projects, such as the one with Department of Corrections and one with a master's student as well. And so we're very excited. So with the self-screen, as I've done now, during my talk, I had the QR code up. So if someone is doing a wellness talk or engaging with the community, you can easily have the QR code. So you're generating accessibility of the tool. Can be used in social media campaigns, can be used in healthcare waiting areas. I'm going a bit faster now because Hala's giving me the daggers here. And also a strategically placed self-screening devices at public. And for practitioners, it can be wherever the practitioners do their work. The purpose of this image is to demonstrate that when we did the official executive launch of the tool, we were able to bring the national executive in. So here you're seeing the Minister of Social Development, as well as the senior leadership of the province of the Western Cape and the city of Cape Town, and the Vice Chancellor of the University of Cape Town, as well as a few department heads. And this is really about making sure that everyone has a sense of ownership, understands the utility, understands how it fits the vision of all of these organizations, And of course, with that buy-in, you are able to then open doors to get further dissemination and use of the tool. And also, this was just a fun event. It was fun. We have fun when we get together. So it's not just here. When we work, we have fun. So it's part of relationship building is not to be too serious. I'm only serious here because I'm terrified of you. But generally, just to have fun and keep it light. So these are just more images of that event. So I hope that in speaking now, I've sort of touched on the areas of these 6 conditions of systems change, and I hope you saw them come through. I hope you saw the policy impact of developing a system that potentially creates a passive risk map and allows policymakers to keep tabs on which substances are problematic and how to mobilize resources. I hope you've seen that because the accessibility of the tool, non-specialist workers and specialist workers can be part of the team. I hope you've seen that by reducing the burden on practitioners, by creating a tool that reduces the burden of time that they spend, that you're able to use those resources more impactfully where they need to be. I hope you've seen the relationships and the connections. I've tried to highlight that. And the power dynamics, keep it fun, right? So there's nothing that puts off a policymaker than a skinny black man telling them what the right answers are. But if you demonstrate impact and you create a friendship and a collaboration, you change the power dynamics, because ultimately we just need to move forward together. And of course, those mental models fall in line. So the next steps are we're integrating the data coming from the ASSIST tool with all of those departments, Central Drug Authority, monitoring and evaluation, our HIV dashboard and as a public health dashboard, and the South African Medical Research Council. All of these feed into the World Drug Report. So we're super excited to start seeing passive risk data feeding through into the World Drug Report. Thank you very much for listening.
I'm afraid to touch buttons. We don't have any more technical difficulties. And I don't read Greek, so I want to end presentation.
Let's try escape.
Escape?
Yes, here.
Oh,
And then you
okay.
can close this one.
Okay.
Oh, it's a PDF, good.
Yes, okay, good. All right.
To just maximize that.
Yeah, well, it is maximized. This one?
No, yeah.
There we go. All right, fingers crossed that everything works. All right, thank you for that presentation. In our following presentation, we'll actually have co-presenters, so we'll have 2 individuals from the ITTC Peru who will talk about the analysis of the experience of a Cascade training model. So first up, we'll have Dr. Chow, who is a member of the International Center for Technology Transfer of Peru. She obtained her bachelor's and master's degrees in psychology from the Pontifical Catholic University of Peru. Dr. Chow completed her specialization in cognitive behavioral psychotherapy at the Peruvian Institute for Cognitive Behavioral Therapy in Lima, and later obtained a doctorate in psychology at the Catholic University in Leuven in Belgium. Throughout her professional career, the focus of specialization and research have been risk behaviors in adolescents and university students, such as stress, coping, health, and addictive behaviors. On this point, her academic and applied knowledge has positioned her as a coordinator of the Psychology of Addictions and Risk Behaviors Research Group since 2014. She also has vast experience in consulting, clinical experience, and the development and implementation of prevention programs, interventions, and health promotion. For this reason, she was the founder of the PUCP Saludable program, of which she was the coordinator from 2012 to 2020. She is currently the director of the Master's Degree in Addictions and Addictive Behaviors at the PUCP and a full-time principal professor in the Academic Department of Psychology of the PUCP. And then we will also have, following Dr. Chow, Dr. Marina Piazza, who is also the ITTC Director of Peru and has significant research, consulting, and clinical experience in the development and implementation of alcohol, drugs, and mental health prevention, intervention, and promotion programs at the local and national level. In the past 20 years at the School of Public Health and Administration of the Universidad Peruana Cayetano Heredia, she has established leadership creating and directing the Alcohol, Substance Use, and Mental Health Research Unit. During the last years, she has participated in the World Mental Health Study, the Genesis, I think is how you pronounce that. Did I get that correct, study? Okay, Genesis study, and the International Alcohol Research Study. She has also led implementation programs such as the World Health Organization IPER program, which is Improving Program Implementation Through Embedded Research Initiative, the Scale-Up of Prevention and Management of Alcohol Use Disorders in Latin America, SCALA, European Union's Horizon 2020 funding, among other studies. So first, we welcome Dr. Chow to the podium. Thank you.
Good morning. I feel so happy to be here and thank you for attending our session. I will present the role of a university system change through the lens of ITTC Peru analysis of the experience of a Cascade training model. As you know, Peru International Technology Transfer Center is hosted at the Universidad Peruana Cayetano Heredia in collaboration with Pontificia Universidad Católica del Perú. It is a convening body to develop capacity and networks in order to connect the different organizations as a system for substance use design, implementation, and evaluation of preventive treatment and rehabilitation programs and policies. The aim of the presentation is reflect on how key system change conditions have been applied to build capacity to provide CBT treatment for psychoactive use in community mental health centers in Peru. Let me explain you that in Peru we have this system in the policy of mental health. We have more than 280 mental health community centers, and it's very important for us to work with the Ministry of Health. And this center provides outpatient and specialized care of people with mental health problems. Why strengthen competencies in substance use treatment? Because limited number of trained professionals in CBT in these centers. It's also area of work is still stigmatized, achieve greater adherence to treatment, limited training in primary care to identify, intervene briefly, and refer to the community mental health centers. Why use Cascade model? First of all, is limited training resources. Also limited academic institution working with the public health system in my country. Cost-benefit in country with limited budget in mental health care. Also model allows to quickly scale up. We have trained 255 students in 5 regions of the country across 3 years. My country, Peru, is very special because we have 3 regions, the coast, we have the ocean, Pacific Ocean, and we have the mountains and the part of the selva, where you can find different kind of region and different kind of geography, and also the people who work outside of Lima receive less opportunity to train in CBT or others ways of capacities. The system to aim to interconnect includes community mental health center with primary care facilities in their territory, public health system regional with national level, academia with public health system. Description of Cascade trainers we call taught model. Let me explain you also that in my university, we have a master program is related to addiction and behavioral addiction. And we have students from the program, and at the same time, we receive student professional from the centers, community mental health centers, and we have an agreement with the Minister of Health, and then we said deliver of training through layers. Master trainers participate in Master of Addiction course and replicate on a more introductory course with peers. It means we have one at the university, and these students replicate following a more introductory course online with 10 students more in each region. One-line self-learning materials allow time flexibility in the tight schedule of professionals and promotes quality assurance. Each master trains 10 professionals and communicates using WhatsApp, chat, and monthly meetings. It's important to say also that these 10 professionals receive the support each month for psychology, clinical psychology, training in CBT treatment. Evidence of effectiveness of Cascade training of trainees taught model. We did a pre and post evaluation of 30 students in second edition of course. Online instrument measure cognitive process and understanding, analysis, and application. We found significant differences between pre and post tests. You see in the table the significant is important, and for us it was a way to know how the course impact in the students. You see also here the pre-tests, the numbers of pre-tests and post-tests in different areas of the scale. You see important increases of knowledge in different aspects, no? Paradigms of cognitive behavioral therapy, fundamental of cognitive behavioral therapy, and also specialized intervention in addictions, cognitive behavioral psychotherapy interventions. You see the numbers. And also it's important, we apply also a qualitative assessment. And in this case, level of satisfaction with the course was medium to high level. Perception of the course development emphasized quality, relevance of content, didactics, development of the human relationship following the mental model, and management of emotion, use of technology and feedback. It's very important to be close with these professionals because they have some doubts and some questions. Marina, it's your turn. Thank you. You can use this and this. Este y este para avanzar.
Thank you. Great. So, as you see, we focus on sustainability by locating our efforts in a master programs that already existed, that is guided by Cecilia in one university, in the psychology school. And we use this course, we strengthen it first with the ITTC Coordinating Center, and also we enhance the capacity of this course because we funded the presence of an expert that was an assistant to the course, and in that way the course could allow a greater audience. So not only the 10 or 15 master trainees that are part of the master program, but every edition of the course allows us to train as master trainers another 10 or 15 professionals that are working in various regions of the countries, and then they commit to be master trainers and replicate this learning experience in another 10 peers of their area. But we are very conscious that these professionals have very scarce time. So we do a balance of the time we ask them to devote to their peers and also provide support with self-learning experiences that are based in an online learning environment in another university, because we work in 2 universities. So what challenges we found in the context for this cascade model? And here the system change model allows us to analyze better those issues. First, that most academic settings prepare professionals to work in a clinical setting without a system or public health perspective. Why would these master trainers would be interested in training other peers if they lack this vision of a system, a health system that needs to be strengthened with their sharing of learning capacities? Another context issue that challenges this program is that the health systems evaluates productivity of professionals based on clinical activities. Each professional has a number of sessions that they have to complete, a number of screenings that they have to complete, etc. But they do not recognize the time that they are using being trained, and also the health system doesn't recognize the time that a master trainer uses helping their peers, training their peers. So this is based on self-motivation at this point, while we develop all the normative elements that are going to provide more sustainability to this. And then another context issue is that within the community mental health centers, the addiction services have less cases because of stigma that reduces referral. And these mental health services still are not that integrated into the health system. And another more practical issue is that limited internet access in the community mental health centers was also a limitation. But when we faced these master trainers to develop their role, training other peers, we had to acknowledge that they had some hesitation. They felt they didn't know enough. This course was designed in the way that the master trainers were participating in learning activities, and 2 weeks later, they were working those contents, teaching their peers. In that way, the memory would be fresh, and the commitment of training others would be active during the period they were receiving training. But they were afraid. They had the model of a very vertical training in which they had to know everything before being able to help others to involve in learning activities. Another issue was that they felt they didn't have experience as trainers, okay? And that they would not be well evaluated by their peers. And also, because of what I just mentioned, the way they are evaluated, they were fearful of not accomplishing their clinical tasks, due to the time devoted to train their peers. So in this situation, what was the way we accommodate the intervention to incorporate these elements of the reality in order to make more flexible our intervention and more responsive. We promote a sense of belonging to a learning community where everybody has something to share. So that was something new for the professionals, this sense of horizontality, and that they should just be able to identify the questions, ask for the answers, provide the answers, and not put themselves into this very vertical and high position of authority in order to be effective trainers. A key issue was to promote an environment of trust where master trainers communicate and recognize their perceived strengths and weaknesses. So team building was essential. And also we had to recognize that there was a technical standard that indicated the responsibility of community mental health to strengthen community mental health and primary health facilities in their competences. So that is in the norm, but was not developed into specific activities. And also we had to promote incentives to recognize these training activities. Other issues more in sustaining this is to ensure the continuity of the course at the master programs, evaluate constantly because we need this flow or feedback in order to establish that this is valuable and works, and develop a guide for the master trainers. So in conclusion, universities are relevant and appropriate settings to generate system change because they are credible. They generate evidence, and change takes time, and universities sustain in time. Also, universities have specialists in CBT, in public health, and have experience generating these self-learning virtual environments that are key in order to translate this knowledge and empower the Ministry of Health to use all these tools, because we are working so that this course is going to be in the national training program of the Ministry of Health. We also have some challenges. We have to show that the university is close to the ground, because sometimes they establish a distance, say, oh, you're in the university, you don't know how this is, you know? We are in the jungle working. We are in the mountains, you know? So we have to show that. And what is essential to our work is to provide continuous technical assistance. We just don't leave our master trainers alone. We continuously meet with them and provide support and see what else they need. And this is done in a circular way. We develop, we disseminate, we implement. And so, just to complete, the Cascade training model then is feasible to implement, is effective to develop competences in cognitive behavioral therapy, is efficient in terms of resource allocation, and is sustainable at the system level. And the university setting offers exceptional conditions to use the Cascade training model as a health system changer. Thank you.
All right. Thank you so much, Dr. Piazza. Before we get to the question and answers portion of the session, let's give our panelists one more round of applause and thank them for their time. All right, with that, looks like we have just a little over 20 minutes for questions for any one of our panelists, and I believe we've got a microphone here for the audience. Does anyone have a question? Yes.
Thank you very much. My question can be answered by any one of the panelists, but maybe Dr. Goodman will help. What's been the experience for you when the need was identified by other bodies rather than the ITTCs? Has engagement been faster rather than when you identify the need and then you engage in the other bodies? I'd like to share your experience. Thank you.
Thanks, Bao. Absolutely. It's actually, I think it's that situation of creating that relationship, that collaborative relationship of trust. Unfortunately, it's not always easy, but once you do, they are then able to express specific needs and then are able to be attentive to ideas to meet that need from you, which might be novel and different to what they might have expected. If you look at the web app assist, it's something that we talk about all the time as ITTCs, or they assist as a tool. But it's not something they would have imagined. They might have thought of a more specific site survey or some sort of other mechanism. But we were able to sell them on the idea that if you use this tool, which orients your services towards a public health focus, as is your focus, then they're able to start seeing the value in that. And as ITTC, we did a needs assessment. Laurie speaks about it from time to time. 2018, we haven't done one since because we just keep getting need. we don't even have to generate need and demand anymore because people come to us and they trust us enough to be able to be innovative and come up with novel answers to their questions. So that's from the South African perspective. I don't know if my colleagues have another.
I might just share our experience when we start a project. I think like when we do some exercise like intervention mapping or design intervention, the first thing to do is to do a thorough review of the literature and then to talk with the partners to see how people perceive the situation and perceive the needs. So I think our role is not our role is merely like to synthesize all the available data and translate them into like more feasible or into like activities. Thank you.
Yes, I will just add to that. I think it is an advantage when a need is expressed and there is an initiative of some organization approaching you, but there's always the need from our perspective to reframe what they are expecting from us, no, and how they understand what they really want, no, and also what is feasible or appropriate for us to provide.
Any other questions from audience members? Yes, up front.
Thank you, Susan. I would like to ask to colleagues from Vietnam, Nguyen. So it's wonderful system program in community. I would like to ask, how do you maintain the online system management? Because it's very difficult to apply to our country. Maybe sometimes they do not have the smartphone anymore and they feel boring because it's not person to person. And the second question is, you mentioned about the mental model changing in the social worker, but how about the mental model changing among the participant, among the patient, among the clients, not just from the social worker view? Thank you.
Thank you, Christiana. Actually, for the first question regarding the platform to do online groups, we didn't do anything very expensive. Like we just in Vietnam we have something like a WhatsApp group, and we do like Zalo group. So we add clients and their family member into just like WhatsApp group, and then the lay social worker, they like every week or 3 times a week they post information regarding we have like a schedule. For example, Monday we're gonna post on health service. On Wednesday we're gonna post on different things. So it's just that, and people interact onto this this platform. And what you mentioned is very critical, and this is one limitation to our project, that we can access only to people who do have some quite good family support, who get access to a smartphone, and we couldn't include people with more disadvantaged background, who have no family member, who have no smartphone. So I think in the future we might find something to address this issue. For the mental models, unfortunately, we didn't think about investigating the experience of how the perception of the client change over time. So we just asked them about the feedback on the intervention, but we didn't really ask them about how they perceive substance use issue, and so I will make sure that we will include that in our future project. Thank you.
Very good questions. Marina?
Thank you very much for very interesting, useful presentation. Because for me, my presentation will tomorrow. I would like ask all presenters. ITTC hosted at the university. What is the motivation for the university change system or participates in the system change? Because there are a lot of non-governmental organizations who is very ambitious and would like also to change a system. And what do you think, and maybe how we can work with the non-governmental organization? But the main, what the motivation for the university?
Sounds like that question's open to any one of our panelists.
Well, I can comment. Our ITTC is based in 2 universities. The Pontificia Universidad Católica del Perú School of Psychology, and the Universidad Peruana Cayetano Heredia, which is a health sciences university in the School of Public Health. So from a public health perspective, being able to improve health in the populations and health systems administration is an essential task, and also from a perspective of social responsibility, which is very important, and that is also for the Catholic University, no, as their mission.
Thank you for the question. Yeah, it's very important because my university and also Cayetano has a direction of universal responsibility, and it's part of our mission, and also because we produce research, and it's important for us not only to publish, it's only to help for instance, the Ministry of Health, in order to give the application of this research. We applied, for instance, in CBT, cognitive behavioral therapy, is based in evidence. And also, specifically, they need these tools to work with people with substance abuse problems, because it's also the best treatment based in this therapy. And for our university, it's important to be part of the society, not only to be in our campus. I can say. Thank you.
So I had a feeling my colleagues would cover most of these things. So I made some quick bullets. From my side, I think it's the research component. So our activities provide a good platform for delivery of research. And in any event, our activities on their own are if you collect data from what we do, it's something that can be analyzed and studied. I think that's part of the impetus for us to make sure that what we do is evidence-based and that we collect data in a way that can be studied in that way. And I think the other piece is the reach of the capacity building. And this goes beyond just the traditional role of universities to provide postgraduate and undergraduate and postgraduate teaching. Through ITTCs, you can reach further, so non-specialists, and reach policymakers and managers. So that's a real benefit, motivation for universities. And indeed, social accountability and that embeddedness in communities is desirable for universities. So it allows them to have an arm that does that. And I think for me, importantly, is that direct operational link to communities, to policymakers, to managers, which can help facilitate responsive programming and responsive priority setting.
I just had, oh, sorry.
No, I just said that I don't have an answer to Irina's question, but I wonder if the other ITTC directors can comment on that, because I think the question is so important. Thank you.
That's exactly what I was going to do, comment on that. Actually, this came out of a conversation I had with Marina previously. You know, a lot of universities are moving to a business model and think about how do they increase enrollment in order to get more tuition so that they can function. And we talked about how having opportunities like the Cascade model or other opportunities to participate with policymakers or participate in the kind of activities that ITTCs do tend to set universities apart that have ITTCs and can attract students. And if you can sell it to university administration as this is something that sets our university apart from other universities, and speak to them kind of in that business model language, that I think can motivate interest for universities to participate in systems change. So while I would love to think, altruistically that yes, universities have a social responsibility function, I do think we also have to think about how it can support their bottom line.
Thank you. And for audience members, Lori Crum, she's the director of the ITTC network and is housed in the network coordinating office, so it's great to hear from her. I think there was a couple of questions here.
It's not a question, it's just to add from Chiang Mai University to your question. It is one of our mission that the university must reach out and serve the local community and the society. Thank you.
Thank you for that addition, Gina.
Sorry. Thank you. I would like to ask Dr. Sibeko, in the process of development of the ASSIST platform, did you find or had to manage some copyright considerations to use the ASSIST?
So because we didn't change the tool fundamentally, we didn't have any concerns. But having said that, we did consult WHO before we started. So they've been part of the program. And it's currently listed as one of the tools for the global coalitions. So one way or the other, you'll probably hear some more about it. And as part of those considerations, we have gone back to WHO and said, now that it's going global, what are the implications in terms of IP in that regard? So we are working through that. But because the tool is unchanged, it's the same as anyone printing the tool and using it anywhere. They don't need to worry about IP because they're using the original tool. If we do make changes, there'll need to be discussions. And having said that, part of the plan is that some of the changes that will happen will be sort of language updates. So it's currently just in English and a couple of South African languages. Hopefully, we're working on securing additional funding. If we're successful, we can then start adding Spanish, Arabic, Portuguese, French, Italian, etc., so that more people can access it. So the short answer is we haven't had to deal with that because we haven't changed it materially.
Thank you. We have time for one, possibly two more questions, if there are any other questions from audience. All right, hearing none, I think this concludes our panel. Thank you again to all of our panelists. And for you in the audience, I'd like to, as we mentioned earlier, this is part 2 of a 3-part series, so we invite you to come back tomorrow to continue to hear about systems change. And we'll be hearing from the ITTC in Colombia, Ukraine, and Indonesia. So thank you very much.